So our first speaker this morning, Jeff Arrington, grew up locally in North Ogden. He graduated from Weber State University and then attended the Medical College of Wisconsin. He completed his residency in obstetrics and gynecology at the Phoenix Integrated Residency in Arizona. After residency, he completed a fellowship in advanced gynecologic laparoscopy sponsored by the American Association of Gynecologic Laparoscopists and the Society of Reproductive Surgeons. He was fortunate to spend his fellowship year working with world-renowned surgeon and laparoscopy pioneer, Dr. C.Y. Liu, I assume. He has presented twice at the World Congress of the AAGL and has served as a co-moderator at the same meetings. Dr. Arrington is married to his wife Angela and has 4 children. And he'll be speaking this morning on GYN laparoscopic techniques.
Thank you so much for the opportunity to be here, and Mark for thinking of me and inviting me. Growing up a local boy, during college worked at the old McCady Hospital and had the privilege of being a transporter phone operator and hearing names and working with many of the physicians in the room and of the area that I respect and feel honored to be able to present to today. As I prepared this talk, I realized that my passion for this discussion and this topic is more than I thought it was originally, and how much I enjoy doing what I'm doing and the training that I've been able to have. There are some video clips in here that have different instruments with their names on them. I just want to disclose that I don't have any affiliation with any of these companies, and hopefully I've practiced enough so that I don't throw out any inadvertent names where I don't mean to. The objectives of the talk today will be first to let you know about some patient awareness data. One of the biggest challenges we have with minimally invasive gynecology is that the patients don't know exactly what's available and what advances have been made over the past few years. Also to discuss some basic office endoscopic procedures, and to discuss the benefits of laparoscopy and provide a brief overview of some of the advances that we've seen in laparoscopic gynecologic surgery. Dr. Whipple mentioned my preceptor, Dr. C.Y. Liu. Back in the 1980s when laparoscopy was getting started, he was a lonely doctor in Chattanooga, Tennessee, and began taking ovaries out through the laparoscope. And at that point, when his colleagues found out he was trying to do this, there were many calls for his medical license to be suspended and revoked because of the cowboyness of the procedures that he was doing. And to look where we are today, almost 30 years later, about the big differences and the big strides that we've seen in laparoscopy. One of the comparisons that I would like to make is the advances in general surgery compared with GYN. Cholecystectomies, appendectomies routinely performed laparoscopically in minimally invasive ways. Also, bariatric surgery over a 9-year period made a 50% jump in the number of those cases done in a minimally invasive nature. Gynecology for hysterectomy, kind of bread and butter procedure, surgical procedure, over the same 9-year period we saw a 10% jump. So we lag quite behind the general surgeons in the advancement of our techniques. And less than 40% of women are aware of less invasive, minimally invasive non-hysterectomy options. The AAGL performed a survey in late 2007 to check on patients' awareness and patients' expectations as they understand their options for treatment of their gynecologic conditions. The number of patients that expected their physician to promote options least affecting their lifestyle was 94%. And the number of patients that expected their gynecologist or their primary care physician to inform them of minimally invasive options was 98% of patients. So we have a responsibility to make the patients aware of what options are available, the pros and cons of all those options, and to let them and help them, guide them into making an informed decision. The first area I'd like to talk about is office-based procedures. Some of these office-based procedures are global endometrial ablation for heavy menstruation, hysteroscopic sterilization, and also mid-urethral sling for stress urinary incontinence. The last one I'm not going to talk about too much because it is not really an endoscopic procedure, but there are some mid-urethral slings that are being made that are smaller in size. You don't have to pass big trocars behind the pubic bone, that throughout the nation some physicians are starting to incorporate these into their office practice. The benefits of office-based procedures, number one, are patient convenience. They know the office staff, they're familiar with the doctor, they're familiar with the surroundings, they're more comfortable in the office atmosphere. Also lower patient cost, and we'll go over that a little bit, and also we're able to minimize the anesthesia risks. Common office-based procedure protocol, cervical ripening agent, pain medicines and anxiolytics, paracervical blocks for pain control and comfort. The first one I'd like to talk about is global endometrial ablation. This is an alternative to hysterectomy. It's used for treatment of menorrhagia with confirmation of benign endometrium. The average pain score on these patients that have this procedure done in the office is about 3.7 out of 10, which is similar to moderate menstrual cramps, as patients rate those pains also. Hospital cost for just the procedure is about $4,500 in a national study. This does not include the anesthesia or the physician fees for the procedure. In the office, the range of patient responsibility for the procedure is about $2,500 to $3,500 with a minimal anesthesia cost. So a significant savings to the patient and to the healthcare system. Levy and Chudnoff in 2005 did a study on hysteroscopic sterilization. And again, the first thing I'll bring up is cost analysis. The pure cost difference between laparoscopic tubal ligation and hysteroscopic sterilization, just for the equipment alone, about $3,500 versus $1,300 for the devices. I put one in there. The only one currently on the market is the Assure device, and their efficacy study has shown a failure rate of only 2 to 3 per 1,000 patients. Comparing that to laparoscopic monopolar sterilization, where laparoscopically the monopolar is the most secure form, that has an overall failure rate of 7.6 per 1,000 patients. So still, the hysteroscopic sterilization is very comparable, very secure. And again, pain similar to menstrual cramping on insertion of these devices. The nice thing about the hysteroscopic sterilization is it takes the major complication risk from placing trocars through the abdomen, where you worry about bowel injury and large blood vessel injury, burn injuries as you're cauterizing the tubes, and it takes those major risks down to the level of a vasectomy. And very feasible for patients to come in for this, have the devices placed, and if they don't have an anxiolytic or significant pain medicines, they're even able to drive themselves home after having the procedure. This is just a little video clip of of a hysteroscopic sterilization. The hysteroscope is inserted, the tubal ostia are both identified, and then a little coil is fed up inside the tube. This coil is released. It's a titanium coil that's coated with Dacron, and after this coil is placed over the next 3 months, that tube will scar in. And at the end of 3 months, a low-pressure hysterosalpingogram is performed that confirms closure of the tubes, and the patient is then protected. And there's the release of the coil, and then again over time that will scar in. We'll move on now to laparoscopy. That's kind of where my training focused. Again, briefly to go over the benefits of laparoscopy. Number one, shorter hospital stay. 2, less blood loss. Quicker recovery. Fewer wound infections. Better cosmesis. And better visualization, especially today when we have high-definition monitors. There are some 3D technologies that are in play that just allow a spectacular vision of small pathology and difficult pathology in the pelvis. Barriers to advanced laparoscopy, again, lack of time for training and residency in OB/GYN residencies where you're learning how to deliver babies. You're learning women's health care and preventative medicine. You're learning the open techniques, which need to be learned and should be learned before moving on to advanced laparoscopy. There's just not a lot of time left, especially with the decreased residency work hours. Also, I feel the major barrier to learning advanced laparoscopy is the suturing skills. It's difficult to suture with straight instruments in a 2D field, and it takes hours and hours and hours of training that many physicians and gynecologists just don't have the time to put in. And along with the suturing is the laparoscopic ability to manage complications, bowel injuries, bladder injuries, that with the suturing is possible to manage most of those complications, and also the 2D vision. The first area I'd like to talk about is uterine prolapse or pelvic prolapse. Minimally invasive prolapse treatments that are available, number one, are mesh kits that are placed vaginally. Again, I'm not going to focus too much on that, but there are some good techniques available, and people throughout the country who are trained well in these have excellent outcomes. The trade-off is a better long-term cure rate for about a 10% erosion rate, but the erosions are typically minimal and very easily managed. I'll talk more in depth about laparoscopic uterosacral suspension as well as laparoscopic sacrocopalpexy. The uterosacral suspension is where we fix the vaginal apex to the uterosacral ligament. The exact location of the ureter is easily visualized. It reestablishes the normal anatomic position with support of the uterosacral ligament, and it can be performed as a same-day outpatient surgery, much like a tubal ligation or simple procedures like that, if that's the only procedure done. Larry Lynn, when he trained at UCLA, put out a paper that looked at 133 patients that had this done. Of these 133 patients, 87.2% still had their support after 5 years' time, and there were only 3 major complications reported in the study with no transfusions and no ureteral injuries. This is a video clip of the uterosacral suspension. A rectal probe is placed in the rectum, and the rectum is deviated to the contralateral side. A bite of the uterosacral ligament is made approximately 2 centimeters medial and 1 centimeter caudad of the ischial spine. The suture is placed, and then here shortly we'll grab that suture and tug on it, and you can see the integrity and strength of that ligament. Once I get the suture pulled through, and then we'll test it real quick. And you'll see that this is a good, strong ligament. The suture's then passed up through the peritoneum to the vaginal cuff, and the posterior rectovaginal septum is plicated to the anterior pubocervical fascia. Next is the laparoscopic sacrocopalpexy. Again, compared to open sacrocopalpexy, which is considered the gold standard for vaginal prolapse, apical prolapse, open cure rate of 78 to 100%, comparable laparoscopic cure rate of 93 to 100. The operative statistics, longer operating times with laparoscopy. There is a much shorter hospital stay and typically less blood loss. We'll move in next to surgical management of deeply invasive endometriosis. I want to talk a little bit about medical management. Endometriosis for gynecologists is a difficult disease, very poor cure rates, and sometimes very difficult to treat. Some of the typical medical managements that are available, one of the newer ones that we're looking at is aromatase inhibitors. Deeply invasive endometriosis has been found in some cases to have aromatase activity, so even though a oophorectomy may be performed, the endometriosis may have the capability of self-perpetuating its own estrogen supply. Cure rate with medical management, 20% in a Lupron or GnRH agonist group, 13% if there is rectovaginal endometriosis present. In the studies that I was able to find on surgical cures, surgical cure rate is not great, but it does seem to be better than medical management. And in all the studies, they showed a cure rate of greater than 50%, but they're still very low. Some preoperative assessment and surgical planning of treating deeply invasive endometriosis, history, rectovaginal examination, vaginal ultrasound, MRI, and IVP if there's concern about ureteral involvement. This is a rectal ultrasound showing a small rectal nodule right here that is important to know preoperatively if possible, so you can do appropriate bowel prep and make arrangements during surgery to have that removed. Vaginal ultrasound in a group in Sao Paulo, Brazil, led by Mauricio Abreu, looked at transvaginal ultrasound, which is comparable and maybe even a little bit better than MRI at detecting these rectovaginal lesions. They've also done a study where they took out segments, or they did segmental resections of the rectal sigmoid with endometriosis and checked the depth of the invasion of endometriosis, and found that if the endometriosis invades the bowel wall to the level of the circulomuscular layer, that they found that on average over 50% of the circumference of the bowel was involved with the disease. And their point was that typically gynecologists, a lot of times when we find rectal endometriosis, will do a discoid resection of the local endometriosis. where it may be more appropriate, if it's deep invasive endometriosis, to do a segmental resection to better treat that. One new and up-and-coming thing that is new over the last few years is narrowband imaging. Here, this just shows a typical view of that. We don't have that here available in our area. Typical laparoscopic view. This one here is the narrowband imaging that can help the endometriotic lesions show up a little bit easier for minute disease and disease that may be missed on a normal laparoscopy. These are just some quick video clips of rectovaginal endometriosis, or rectal endometriosis. This is a nodule in the anterior wall of the descending sigmoid colon. This is an obliterated cul-de-sac. It doesn't look too obliterated until that posterior aspect is opened up, and endometriosis completely invading the rectal wall and the vaginal septum. And this is a patient with hysterectomy performed. This is the one I'll need some pausing help if I can. Bowel pulled up to the posterior uterus. The ureters have been opened on either side, creating a safety zone. These adhesions are taken down. Go ahead and pause it there if you can. The bowel is taken down off the posterior uterus, allowing the top of the uterus to be removed safely. In this part here, you'll see a uterine sound as the video plays, a uterine sound delineating the cervical canal. All this area from the top down to the bottom where the rectum starts is endometriotic nodule. There's the uterine sound at the top, and that whole nodule is able to be excised with the visualization and assistance of rectal probes and things like that. Once the bowels move down off the posterior cervix, we're able to remove the cervix, and you'll see how much easier. There's still a little bit of residual endometriosis here, but step by step and with careful dissection, it is possible to remove these dense, extreme lesions of endometriosis. And there's a small little bit of endometriosis left on that rectovaginal septum that's able to be removed. And then this next one shows that void where that nodule was removed, and then the vaginal cuff closure. Next, I'd like to talk about laparoscopic hysterectomy. Again, a very common procedure performed for many conditions and many reasons. Laparoscopic hysterectomy has the same indications of abdominal hysterectomy. These are large uterus, other pelvic pathology requiring evaluation, prior abdominal surgery, inadequate uterine descent that doesn't allow it to be performed vaginally, and not a substitute for vaginal hysterectomy. And nationally and worldwide, there's an argument whether or not the benefits of supracervical recovery may make it a little bit more, could make it a substitute for vaginal hysterectomy, because we don't have to worry about that vaginal incision healing. Patients are able to return to work as soon as they feel ready to. Very, very few lifting restrictions and recovery restrictions. That's a whole other debate for another day. The pros and cons of laparoscopic hysterectomy. First, the pros: there's less blood loss, shorter hospital stay. Patients have been known to go home within 6 hours of hysterectomy. Typically, patients will go home less than 23 hours. Smaller incisions, less wound infection, less time off work. With the economy the way it is today can make a huge difference. And also lower cost to society, and we'll get into that in a little bit. The cons are iatrogenic injury. Again, there are a few more recent studies that are showing that this is not as big of an issue as we thought it was once in the past, once the surgeons overcome their learning curve. Also, the risk of cuff dehiscence. We use a lot of energy sources when we remove the cervix to go around the vaginal cuff. The cuff dehiscence rate is higher with laparoscopic hysterectomy than it is with vaginal or open. Many thoughts are because of the injury, possibly because of the magnification of laparoscopy. Our suture bites are not as big as what they normally would be, but that is not completely teased out yet. Still, the cuff dehiscence rate is less than 4%, with abdominal hysterectomy somewhere between 1% and 2%, so not dramatically increased. Also, the risk of large vessel injury comes along with any laparoscopic procedure. Also, higher operative cost. Again, much of this has to do with the new instruments that are being used, energy sources, disposable trocars, using simple bipolar forceps, Kleppinger forceps, and disposable endoshears or endoshears and reusable trocars, many of these costs can be significantly decreased. Also, longer operative times. Again, learning a new procedure. I found that as I've gained more experience, those operative times are very comparable to open hysterectomy times at this point. Nationally, the total number of hysterectomies performed abdominally is about somewhere between 60 and 70%. Vaginal hysterectomy, 25%. Laparoscopic hysterectomy, 9%, and then robotic-assisted hysterectomy is 4%. It is possible, as a surgeon becomes more proficient, that the numbers on this can be completely flipped, to where laparoscopic would be in the 50 to 60% range. Vaginal hysterectomy should stay the same, as laparoscopy is not an alternative for vaginal hysterectomy, and then to have the open hysterectomy rate in single digits. Cost analysis studies that compare the laparoscopic versus abdominal. Elstrom looked at direct hospital costs. These were 1.7% more costly for laparoscopic hysterectomy over abdominal hysterectomy. Again, these are pure surgical costs. The indirect costs, looking at patient stay, postoperative complications, postoperative follow-up, cost to society, finances lost due to the patient being out of work, were significantly less, with laparoscopy being 50% less costly to the patient. The total cost difference, taking all of that into account, is 23% less with laparoscopic procedures. And again, just a study that looked at the influence of using non-disposable instruments can make that direct cost almost equivalent. Looking at pure hospital cost for the hysterectomies, this one will compare abdominal hysterectomy, laparoscopic hysterectomy, and robotic hysterectomy. Again, huge hospital costs, which we would expect with a longer hospital stay. And again, with the robotic, let me step to the side. With the robotic and laparoscopic, the surgical costs, of course, are more expensive because of the instrumentation that's needed and used. But in the end, when everything is taken into consideration, the minimally invasive approach seems to be, at least in this study, more cost-effective. The next part I'd like to go into is robotics and gynecology. This has been a huge thing over the last few years. Nationally, every time I go to the AAGL meeting, there's two whole sessions dedicated to robotics and robotic procedures. Oncologic procedures with aortic node dissections and things like that is just remarkable what these surgeons can do. The pros of robotics and gynecology, the biggest one is the shorter learning curve. Again, to learn the advanced laparoscopic procedures with what we call straight sticks is significant. Hours and hours and hours of practicing learning how to suture. The robotics completely takes that, or nearly completely takes that away, because it allows that surgeon to use the wrist and use the normal motions that we would have in a typical surgery. Same benefits as typical traditional laparoscopic procedures, and allows minimally invasive option for benign and neoplastic disease. The cons, the biggest one is the facility startup cost. Very expensive piece of equipment. Initially, there are longer operative times as surgeons are learning new techniques. The biggest thing for women's health care is it allows some of these procedures to now creep in to our practices, and allows more gynecologists to learn the minimally invasive techniques and offer their patients the same minimally invasive options that have already been adopted for males with prostatectomies and other conditions. So it can be a huge boon for the quality of women's health care. Advantage of robotics, again, same as laparoscopy, shorter learning curve, less port incision trauma. The camera is a 3D. It's the only 3D camera that we have available that allows depth perception during the laparoscopic surgery, and also high-definition vision, and less surgeon fatigue. And from what I could tell, I have never found a study on this, but from personal experience, spending a surgical day with two or three major surgeries, invasive endometriosis, difficult hysterectomies, standing in a patient's side with my head cocked one way and my body cocked the other way, and my foot on a cautery pedal, much different than sitting down at a console and operating comfortably. Certainly less fatigue in my experience than traditional laparoscopic operating positions. Robotic procedures that can be performed, again, hysterectomy, myomectomy, sacrocopalpexy, and endometriosis, the same ones that we perform with minimally invasive laparoscopy. This is a little video clip just showing a robotic arm on your right. Traditional laparoscopic suturing on the left, just so you can look and see the difference. And in this one, pay attention to these robotic arms, and you'll notice the wrist movements that we have, where traditional laparoscopy, everything is straight except for the grasper and lateral movement. And those little robotic graspers, again, completely mimic the surgeon's hand. Whatever the grasper is doing, that's what my fingers are doing. Whatever the wrist is doing or bending, completely mimics it compared to the straight instruments on the left. And after this one's shown, the biggest difference will be seen in just the ability to tie the knot, so to speak. Just a real quick example of this. The next one is going to be a video clip of, this is a fibroid that was removed from a uterus. And again, just a little bit better picture of how easy it is to throw sutures with these instruments. Makes removal of uterine myomas much, much easier to be performed laparoscopically, with the ability to close the deep layers of the uterus in a relatively simple fashion. And then in summary, to end the talk, again, patients expect to be and should be made aware of minimally invasive options. As this becomes more prevalent in the community, I really see a huge benefit to the women of our community, allowing them to take advantage of those laparoscopic benefits. Office-based procedures offer less invasive treatments with a lower financial burden. And then most abdominal procedures, again, can be performed through laparoscopic means with similar operative outcomes to the open procedures. And I thank you for your time. Are there any questions? I never have done Essures with ablations, and the biggest reason the FDA came out stating that we shouldn't, and the big reason is because they were concerned if you do the ablation first, there can be uterine scarring that could give you a false occlusion on the hysterosalpingogram. There are still a number of people nationally who do it and don't have a problem with it. If I do have a patient that wants both of those done, I will do the Assure first, do the hysterosalpingogram, confirm the closure, and then go back and do the ablation. And having that Assure coil in there may change a little bit about the option that I use to do the ablation, whether we use electricity or whether we use a water mechanism, something of that nature.